Hello, everybody, and welcome to the Hughes Clues Shock, Hypovolemic, and Cardiogenic. What do all shock states have in common? Well, all types of shock result in inadequate or decreased tissue perfusion. And whenever I say the word perfusion, you need to think oxygen. So if there is decreased tissue perfusion, there is decreased oxygen that is delivered to the cells. Now, it's very important for you to recognize this is decreased oxygen delivered to the cells. This does not mean that there is decreased oxygen in the blood. Totally different thing. This is decreased oxygen to the cells. So what are the consequences when there is diminished cellular perfusion? So again, we think perfusion, tissue oxygenation. If the cells do not have oxygen, then the cell will do anaerobic metabolism. And a result or a consequence of anaerobic metabolism is that a lot of lactic acid is produced. And if a lot of lactic acid is produced, then that will drive the pH down. And the pH being acidotic can further decrease the cell's ability to function, and you're going to ultimately have death of the cell or death of the tissue. Now, it's not really that, it's so generic when I say cell or tissue, but what I've got here is, let's be specific. Let's say renal or kidney cell. And so now put the sentence and do the exact same thing, and you've got a kidney cell that's not getting enough oxygen, or a heart cell or a brain cell. And that kind of should indicate to you the seriousness of this situation. Now, if you're an inquiring mind and you're like, okay, how is it that anaerobic metabolism causes lactic acid production? This was covered in Patho, which I realize you've slept since then. But if you want me to send you some more information on that, then just email me. You don't have to know it for this course. But I know there's many of you that are like, I can't get this unless I get the whole pieces together. So just email me. So what is responsible for tissue perfusion? In other words, how is it, or how does it work where oxygen gets dropped off to the cell? I mean, doesn't it just automatically happen? And the answer is no, because an appropriate force, think of this person right here, this little cartoon guy. An appropriate force is necessary to ensure that not only blood flows to the heart and other organs, but that oxygen gets kicked off that hemoglobin, because oxygen is really nice and comfy nestled on the hemoglobin. And so there has to be some kind of driving force that pushes or allows the oxygen to get off that hemoglobin and jump into the cell. And what is that driving force? Well, it's the mean arterial pressure. And the mean arterial pressure has to be maintained for oxygen to jump off the hemoglobin. Now, what is mean arterial pressure? You've probably heard about it, but what does it mean? Well, it means, or it is just like what it says, it's the average pressure throughout the entire cardiac cycle. We know that when you look at a blood pressure, you've got a higher number that's systolic and then a lower number that's diastolic. Well, we want to know what the average is. And so the average is the mean arterial pressure. And you don't usually have to calculate it, because modern day blood pressure machines, non-invasive automatic blood pressure machines, and the cardiac monitors automatically calculate it for you. You're going to have to calculate it in this course. Now, what should the mean arterial pressure be? Well, there's a lot of different sources that will list 60 millimeters of mercury. Some will say 65. Probably the majority of the sources really list 65 should be the lowest that the patient should have. Look at your course notes in your semester. I don't have enough time to read Dr. Reed's notes every semester. I know you can relate to this. So if Dr. Reed says 65 or 70, you just must be in the know during your semester. So again, calculated MAP is usually there for you, except on critical care test. So how do you calculate the MAP? And we're going to do a little exercise by saying you've got two patients. One's their blood pressure is 90 over 60, and one their blood pressure is 100 over 40. And the mean really does tell you who is the sicker patient. So we look at the formula for the MAP, and you don't have to memorize this, you can write this down. But the systolic blood pressure, you add it to the diastolic, and then you add it to another diastolic. So in other words, whenever there is the cardiac cycle, systole, which is the ejection of blood, happens very quickly. But the filling of blood during diastole is exactly 2 times longer than systole. And so that's why there's actually mathematically 3 parts to the cycle, the cardiac cycle, and that's why it's systolic plus diastolic, and then because you have 3 values, anytime you're going to calculate the average, you have to divide it by the number of components, 3 components, divide systolic plus diastolic by 3, and now you have the MAP. So when your patient's blood pressure is 90/60, well, the MAP is 70. Woohoo! So that's a good one. Then if your patient's blood pressure is 100/40, then you look at the MAP, and that's 60. So when we look at who's the sicker patient, we see that the patient with the blood pressure of 100/40 is the sicker patient, because that MAP of 60 is not anything impressive. And so we probably need to do something about that. Now let's use a systematic approach. And what would the patient assessment findings be if you have a patient who is either in shock or is at risk for shock? So again, I have lots of different systems here, so I'm going to just kind of touch on them very, very shallowly. So we think about neuro, and we know that the brain has to have oxygen. In fact, the brain cannot do anaerobic metabolism. So it stands to reason that very early in a low perfusion state, you're going to have altered mental status. Now, whenever there is a low perfusion state, one of the things that occurs is compensation. And you know that in a low perfusion state, there is the activation of the sympathetic nervous system. I believe we've talked about this. If it still doesn't make sense to you, then email me a question. But the sympathetic nervous system is your fight or flight. And so you need really good vision. You need to be able to see in the dark and in the light. And so the sympathetic nervous system, because you're running from, the bear or the saber-toothed tiger, will cause dilation of the pupils. Cardiovascular-wise, you're going to see an increase in heart rate. The patient may be diaphoretic, but their hands and feet are going to be cool. So they're not sweating because they're hot. They're vasoconstricting. The pedal pulses are not likely to be present because, again, if you remember, vasoconstriction will cause that blood to be pushed or shifted to the core, and so the feet are out of luck, and so the pulses may not be very good in the feet or even present. Prolonged cap refilled, a narrow pulse pressure, which we will talk about in greater detail. Just hang 10 on that, on what that is. Just know for now that you'll see a narrowed pulse pressure when your patient is in shock. What about the respiratory system? You're going to have an increased rate and depth because of the lactic acid production, and also because of the sympathetic nervous system activation, as well as the decreased cellular perfusion. In other words, the brain cannot do anaerobic metabolism, and so the brain's going, yo, where's my oxygen up here? And lungs, you better breathe a whole lot faster. And so there's a lot of reasons why the respiratory rate is rapid. You need to know that it is. GI system, you could have hypoactive bowel sounds related to decreased gastric motility because, we don't really need blood in the gastric system if we're running from a saber-toothed tiger. But if your patient's in a state of shock, well, you might notice that there is an increase in the gastric residual on the tube feeds. So that might be an early indicator for you as assessment goes. And then in the genitourinary system, we know that the output, the urine output, which is a huge first-time indicator, could be less. And in our course, what less means is that it's less than 0.5 to 1 mils. The urine output should be greater or equal to 0.5 to 1 mil per kilogram per hour. This is very important for you to recognize because urine output is really a very early indicator that things are going wrong, because the kidneys do receive a lot of blood and a lot of oxygen, therefore, and so they get really cranky when they don't get enough of blood and or oxygen. Now, I've said to you that these are very general, very broad. There's some very specifics that are listed in your cardiogenic, or rather, yes, your hypovolemic and cardiogenic shock worksheet, because I don't want to just go on and on for those of you that get this. All right, so let's say for an individual who has been very critical, the physicians put in a pulmonary artery catheter. And what about the measurements of the pulmonary artery catheter hemodynamics would kind of indicate to you that there is a potential for a shock state? So when we look at the measurements, we see the ones before you. We're going to go through them as on the next slide. But the questions that I'm going to ask you are, what should the nurse suspect? In other words, what kind of shock should the nurse suspect with this hemodynamic parameters? And what are the causes of that shock that is identified by these hemodynamic parameters? So if you want to play along, then pause the recording and try to figure this out on your own first. Otherwise, just keep going and get it all here. So when we look at the measurements that tell us about volume, hopefully you've already done the hemodynamic presentation. Otherwise, this might be a little bit confusing to you. So do that first, then do this. So let's look at our hemodynamics, and we see the measurements that indicate volume, central venous pressure. I say CVP, and your brain should have gone to right atrial pressure. So the CVP is 1, which indicates that there is a low volume on the right side of the heart. And then at the pulmonary artery diastolic, that's the bottom number here, is 2. And that indicates that there is a decreased pressure and therefore decreased volume on the left side of the heart as well. And we also see when we look at the next value that the cardiac output is low. It should be, or cardiac index, cardiac output adjusted for size, is low. And it's 1.8. And we can relate that if there is less volume in general, then the cardiac output's going to be low. I mean, if there's less volume coming back to the heart, to the right side of the heart, then that means less going to the left and less going out from the left. So it stands to reason that if the volume is low, so will the cardiac output be somewhat decreased or markedly decreased, depending on the patient's tolerance. Then we look at the next thing and we see the systemic vascular resistance at 2,000. Normal is between 8 and 1,200. So we see that this patient has marked vasoconstriction. And we know that as soon as the cardiac output goes down for whatever reason, in this scenario, the reason is low volume. We know that the RAS will kick in and that will cause vasoconstriction. And this is compensated for the low cardiac output. So again, as soon as the cardiac output goes down, the kidneys are going to go, yo, where's the blood? They're going to release renin, which goes to angiotensin II and causes vasoconstriction. So then we notice that the heart rate's 110. This is also compensation. Where does this compensation fall? Well, actually, what happens much faster than the kidneys is the baroreceptor. I call them Mr. and Mrs. Baroreceptor. They're located in the ascending aorta and in the carotid. And as soon as pressure goes down, I think of them as a speed bump. As soon as pressure goes down or the volume of blood goes down at the receptor, which is in the ascending aorta. So they're like Johnny on the spot because they're right after the ventricle. The baroreceptor is going to go, yo, there wasn't a whole lot of blood that just zoomed by me. And that is what activates the sympathetic nervous system. So the sympathetic nervous system from the baroreceptors is very, very quick on the uptick. Whereas the renal system, you know that as soon as the cardiac output goes down, then the kidneys sense it and they'll secrete renin. And then renin has to be converted to angiotensin II. Well, that's not a lickety-split process. Yeah, it happens pretty quickly, but it has to circulate. And so it's the baroreceptors are really much faster on the tick for whenever the cardiac output goes down. But no matter, we know that we have compensation by not only one but two systems, the baroreceptors and the sympathetic nervous system, and the renin-angiotensin-aldosterone system. So yay, lots of help or backup for when problems occur. So what should the nurse suspect? Well, this one's easy. Hypovolemic shock, duh. We have low volume, therefore we know that the word for low is hypo, and we have volume, less volume, so hypovolemic shock. What are the causes? So, of course, the obvious ones are blood loss or fluid loss. Say if the patient is not only having vomiting and diarrhea, but they won't drink anything, because if you know that you vomit every time you drink something, you're not going to drink anything. And then also think about third space, because third spacing means that there is a movement of water from blood to tissue, which means it leaves the vascular space. And we see this with liver disease and, of course, burns. Hopefully you will see these scenarios or have seen these scenarios, but you got to think about them, that fluid volume shifts occur with these diseases or illness states. When we look at the key characteristics of the hemodynamic parameters, did I just move that back? Oh, no, I didn't. I'm sorry. I had a little brain moment. All right, so with these key characteristics, then what are the hallmark characteristics and what's the treatment? Now, why do I do it in this drug out kind of way? Because you all going, I got this, I know what the answers are. And I do get that you are smart and that you get it fast. The only reason why I'm doing it this slowly and in this direction is you don't ever know how Dr. Reed's going to answer the question. You may be asked from here's the problem, here's what you did on the treatment, what hemodynamic parameters would you expect, or here's the hemodynamic parameters, what kind of characteristics would you see? So there's so many ways to ask a question, so that's why I'm kind of dragging this out, so bear with me. So we see what the hallmark characteristics are. The cardiac output's low, the CVP's low, the PAD or PAWP, they're all low. That's easy. What's the treatment? Well, when the tank is empty, and when I say tank, I mean the vascular space. So when the tank is empty, you've got to give volume. Now, what kind of volume would you give? You would give Ringer's lactate, lactate Ringer's, potato, potato. You would give normal saline. You could give blood products or albumin, because those are volume expander, or albumin's a volume expander. Blood products would be preferred, because if the patient has a traumatic injury, we know that I could give tons and tons and tons of normal saline, but if it's traumatic, normal saline doesn't carry oxygen. So if the patient loses blood, then you know what? You better give blood back so that they have oxygen carrying ability. And what tells you that the tank is full? Well, the tank is full when the CVP and the PAD, PAWP are increased. And I don't mean by increased, if the CVP was 1, I don't mean up to 2 or 3. I mean full, because we want the tank to be full. Or we could also notice that, you know what, the heart rate's going down and this SVR is also going down. So those could be indicators that, you know what, for this patient that I just gave 1 liter for, that's enough to fill that patient's tank. Whereas patient B may need 3 liters. So, you know, volume is just volume, and every patient might be different. So you really can use these hemodynamic parameters to really guide treatment, to tell you, the nurse and the physician, that, hey, you know, giving a liter was more than enough to fill that tank. Now, do notice that I've used PAD because I try not to give you so many values, because I don't want to talk on and on more than I already do. But I could have given you the PAWP. Remember that PAD and PAWP both tell us about the volume on the left side. All right, take a breath, take a pause. We're going to move on to a new scenario. Oh, no, we're not. We're going to keep the same scenario. All right, never mind. All right, so instead, let's say that the nurse obtains the following measurements. So here's the measurements. Yes, these look familiar because they're the same ones. And you, the nurse, then identify, you know what, this patient's volume is pretty low and something needs to be done. But you can't just give normal saline. You need a physician's order. So you notify the physician, and this physician is a resident, which means they're a newbie. And the physician says, oh, well, what's the blood pressure? And you might say in our earlier scenario, I don't know if I even gave one, but let's say that you told the physician, well, the blood pressure is around 90 over 40. And the physician might say, oh, well, that blood pressure is really, really low. You need to give a dopamine drip. So what are your thoughts on this order? First off, you have to know, what does dopamine do? And dopamine is a vasopressor. And what your head should say is, I really feel that the dopamine may be given tomorrow, but not today. I really feel my recommendations are, or I would recommend, or I suggest, or don't you want to fill the tank, give them some fluid? Because giving a pressor for a patient with a low blood pressure who is volume depleted, in other words, the volume depletion is the cause of a low pressure, is really not going to work until you get the tank is full. So you've got to fill the tank first, and then once the tank is full, and by full I mean full, all the way up to, say, CVP of 8, then perhaps you can give a vasopressor if the blood pressure is still low. Now we're moving to a new scenario. Deep breath for all of us, myself included, and a sip of water. The pulmonary artery catheter is in place. Most recent measurements are, and here we go. What should the nurse suspect, and what are the causes? So when we look at the scenario, we see that the central venous pressure, I say CVP, you say right atrial pressure, is high. If the pressure is high, the volume is high, and this is on the right side of the heart. Then in the PAD, pulmonary artery diastolic, we see that the pressure is high, it's greater than 12, and therefore the volume is high on the left side of the heart. Then we notice that the cardiac output is adjusted for size is low. The cardiac output is low. The cardiac output is low in the presence of plenty of volume. That heart should be pumping, and it's not. Therefore, that cardiac output is a problem or has a contractility issue. That's the problem. This patient's low cardiac output is a result of not too little volume. There's plenty of volume, but it is a result of a contractility issue. And then we have an SVR of 2000, and we know, we've already talked about that in great length. That's compensation because of vasoconstriction. And we know that the heart rate that is elevated is compensation for the low cardiac output and sympathetic nervous system activation. So what should the nurse suspect? Well, you've identified that this is a contractility issue. We should consider that this is cardiogenic shock. Now, probably on your exams, you're going to have a little bit more of a scenario. A scenario will read that the patient just had an MI, or the patient has a history of heart failure or something. It's because usually the causes are ischemic, such as a myocardial infarction, long-standing chronic angina, unstable angina, or long-standing hypertension, or long-standing heart failure. Any of those scenarios would essentially can worsen the cardiac function over time, and then the patient suddenly goes into cardiogenic shock. So again, with these hallmark characteristics of volume, what are the hallmark characteristics written down in verbiage, and then what was the treatment? So when we look at the hallmark characteristics from what we see here, we see that all of the volume levels are greatly high, that the PAD is high, the PAWP would be high had I given it to you, and the right atrial pressure or CVP is high. But in the presence of lots and lots of volume, the cardiac output's low. So this is the hallmark characteristic of cardiogenic shock. So what's the treatment? Well, we're going to fix all of the problems. So this long list of fixing problems should say to you that, you know what, cardiogenic shock is pretty complex and these patients are very sick, and that is the case. So what is the first thing we're going to do? Well, the patient's got a lot of volume on board, so we need to get rid of the excess volume, and we're going to do that with diuretics. Now, this is where students will email me and go, whoa, wait a minute. you've got a contractility problem. Why wouldn't you take care of the contractility problem first? Well, we're going to do the contractility next. We're going to give a drug that helps with the contractility, or positive inotrope, DIG, which we don't usually use in a critical scenario, and dopamine, dobutamine, epinephrine, and milrinone. So what's the story? Why wouldn't we give that first? Well, first off, it's only on nursing exams where you have what do you do first. And the reason why you would give the diuretic and get rid of the volume first is the volume weighs a lot. Now, you know that volume weighs a lot because you know that if your patient has heart failure or kidney failure, or there's some concern with volume overload or volume retention, what do? Well, you weigh the patient, and you know that they weigh more because they're holding on to volume. So water's not light, it's heavy. And that means something heavy, and a lot more of it means that's a lot of work for the heart. So we got to get rid of that heavy stuff before we say to the heart, you need to pump better, because we don't want to make it pump better while keeping the heavy load. We want to lighten the load and then make it pump better. Now, in reality, if I were a critical care nurse, especially an ER nurse, and a patient came in with cardiogenic shock, I'm going to give the diuretic very quickly, zip in that Foley, and then I'm going to give the positive inotrope. It's only a matter of minutes between the difference of giving the inotrope and the diuretic. But, you know, on critical care tests and any nursing test, there's always a what do you do first thing. So get rid of the volume first, then start with the positive inotrope. Notice that we have an increased systemic vascular resistance, and this was mentioned because of compensation for the low cardiac output. And in our scenario with hypovolemic, we didn't really mess with that because we figured, hey, it'll right itself as soon as we give the patient volume. Well, here's the problem. We know that cardiogenic shock means that there's very, very poor pumping, which means the heart's workload is, on a good day, is very hard for it to function. In other words, the heart is struggling to pump. So when you increase the volume, you've added more work, and you've also added, when you have a systemic vascular resistance that's high, which reflects vasoconstriction in the artery, because that's where we're measuring SVR in the artery. So if you have the aorta and the arterial blood vessels that are squeezy-tighty vasoconstriction, that is a lot of workload for a ventricle that ain't doing so well as it is. So we may, after we give the diuretic and the positive inotrope, the physician may prescribe something for the failing ventricle, a vasodilator. Now, you know that vasodilators can drop the blood pressure. And if there is, on the critical care test, the blood pressure is given to you and it's super, super low, you may not want to give a vasodilator until the blood pressure comes up. If the blood pressure is not listed, then assume that this vasodilator is okay to give. So that's kind of a rule with Dr. Reed. If it's not written on the test question, you cannot assume that the blood pressure is abnormal, low, or high. So here's your options for vasodilators: nitroprusside, nicardipine. Heart rate. Well, the heart rate's high because of the low cardiac output, and we know that's because of sympathetic nervous system activation. And it is unlikely that physicians would prescribe a drug to decrease the heart rate because because that's a lot of stress for the heart, creates a lot of need for oxygen. But they may give a beta blocker. It's unlikely because beta blockers are usually contraindicated. But you do have to think about the fact that an elevated heart rate is an increased workload for the heart. So it may be done. It may be dealt with. We have completed all of the material for the hypovolemic cardiogenic shock. So here's what my suggestion is for you. I call this the shock grid, is what I term this. And I think for an exam success strategy, because there's so many times in an exam that you get stressed and therefore your brain doesn't always think clearly. And sometimes, because look at all these arrows, they're going in all these different directions, and so you get confused a little bit. So my recommendation to you is to put this shop grid down on your exam sheet, because this way sometimes your brain will have a little bit of a break. Students will still get it mixed up even though it's on their sheet. So not only do I tell you, put it down on your exam sheet, but make sure you look at it, especially if there's 60 questions and on question number 58, when your brain is pretty dang well fried, be sure and look at it so that you don't get confused. I hope this has been helpful. Email me if you have any questions.